targeted group compared to the non-targeted. So you see how everything again maps onto the PICO and what are the main elements of your study. So oftentimes I will read the background of a student's, their background, their literature review, and then I get to their research question and I'm like, wait, where did this come from? So your research question should be a natural extension from the literature, from your problem, the literature that you reviewed, the gap, and then the issue that you're specifically focusing on. I should not be surprised by your question after reading your literature, okay? All right. This next part is to understand what type of research will I be proposing? All research falls into one of these basic categories. Basic descriptive study. Now, when I say basic, it doesn't mean low level. It just means what are the foundational information that we need to better understand this issue. Formative research, which is developing intervention components. Feasibility study, which is testing, some preliminary testing of an intervention. Pilot tests, randomized clinical trials, implementation research, or secondary data analysis. That is missing. So when you're proposing your research design, you will be proposing one of these types of research studies and the type of design that's appropriate for each of these types of research. When you're thinking about providing evidence for the approach that you're going to use, it's important to use preliminary data. Preliminary data might be from the literature. It might be from your advisor's prior work, or it might be based on some work that you've also done. This preliminary findings helps us to support the scientific premise of the study that we're proposing. But however, preliminary studies, again, keep in mind, they can come from the literature. What are the results from the intervention that has an evidence-based intervention that you're also proposing to use? What is the evidence for it? That's where you would include it. Or you could show results from your own prior work. Okay. So then we look at the research design. Now, there are many, many different types of research designs: quantitative, qualitative, mixed methods. One is not better than the other. It depends on what? It depends on the research question. So many people will say, you cannot do a qualitative study for your dissertation. It's a weak method. No, it's an appropriate method for the right research question. And so if I'm asking a question related to an experience or phenomenon, then qualitative methodologies are appropriate. I want to use rigorous qualitative methodologies, but the key point here is that no one type of research design is better than the other. It depends on the research question that you're proposing, right? And is it the appropriate fit? So is the design appropriate for the research question? What is the risk of bias if I use this type of design? What's the risk of bias if I use pre-post test, single arm versus randomized trial with intervention and control group? How are there ways to reduce the bias or control it, or are there alternative designs that you could consider? When you're thinking about your research design, it is appropriate to think about each of these questions. Is it appropriate for my research question? What is the risk for bias? And are there other approaches that might be better? So the approaches that you can use for qualitative, quantitative, and secondary data analysis, again, there are many different methods and designs within those, again, it's up to you, your understanding of the literature and your consultation with your advisor to choose the most appropriate design. Okay. But you will be asked very early on to think about what design. Once you think about the design, it's important to know what are the hallmarks of best practices for each of these designs, and how do I make sure that I'm following these best practices. Oops, stuck again. Uh-oh. Okay. So again, when we talked earlier about our research designs, when we're trying to explain it to our advisors or get consultation, we want to make sure we clearly understand each of the components of our design. And one clear way of doing it, to talk it over to get consultation, is to make a study design figure that shows the design, shows your recruitment, your randomization, and the procedures that you'll use. We'll randomize. Everyone will have a pre-test. The intervention group will get the telehealth. The control group will get the standard of care. We'll do a post-test at the end of the intervention, and then at 3 months, we'll do a follow-up. In one picture, becomes crystal clear to me what it is, the big picture of what it is that you're trying to propose. So I really recommend that you create a figure when you're developing your design and your procedures that really spells it out in a very easy way to follow. Now, there are much more complicated designs. This is a smart design. This is one of my currently funded projects. But again, whatever is the best way of illustrating what you're doing and getting feedback about your design is best. So simpler can often be better. The next thing that you need to think about is your target population. Most of the time you will know your target population based on your problem and any potential gaps, or if there's a high risk population. But you need to think very clearly about your inclusion and your exclusion criteria. That is how you determine who will clearly be in your study and who will not be. There's some key considerations that you should think about when you're thinking about your inclusion and exclusion criteria. The first is whether or not you want a very homogeneous population, or if you want a more diverse population. So let me give you an example. If I'm focusing on quality of life, and among cancer patients, and I recruit lung cancer, breast cancer, skin cancer, colorectal cancer, blood cancers, and I'm interested in general concepts around the type of support that is needed for cancer care. That is fine to have a heterogeneous group, because I'm interested in developing cancer support services for our patients in general. But we know that some patients have more needs or different types of needs. And so, for example, for colorectal cancer patients, there are lots of different types of quality of life issues related to the ostomy, related to returning to work because of issues of avoiding. And so it is sometimes better to have a more homogeneous group, only include colorectal cancer patients in that case. So it really depends on your research question, whether or not it's okay to have a heterogeneous population, or if you're interested in one specific target population. But even sometimes we think, well, I'm interested in breast cancer patients, so I will only include my breast cancer patients. Exclude colorectal prostate. Are you interested in quality of life? Quality of life differs for early stage versus late stage versus patients who are in treatment versus those who are receiving palliative care. So again, based on what your research question is, depends on how narrow or how wide you will focus your inclusion criteria. Okay, but it should be justified based on your research question. Okay. Now we move into thinking about recruitment. Here's another issue that comes up. I do yes.
Oh, Dr. Matthew, I just feel like when we conduct study and include heterogeneous sample populations, and I feel like it is hard to find a journal to publish. But for the homogeneous sample, it's more easier. I think.
So if I'm interested in the relationship between stress and cigarette smoking, I can have, it's best for me to recruit a very diverse population. I'm interested in smokers, but I'm interested in male and female and older and younger and different race ethnicities, different education levels, because I'm interested in the general principle of what's the relationship between stress and smoking behaviors. After I've looked at that main research question, then I might look to see, are there differences based on demographic characteristics that increases risk or enhances the relationship between stress or reduces the relationship between stress and smoking. So it really is dependent on the research question, but it is easier to convince a reviewer that this is applicable to breast cancer stage 1 who are at the beginning of their treatment. It's very clear, right? So if you're looking at a more diverse population, you need to explain why, that we understand that this is a general principle that's related to smoking, and we're looking at that.
Oh, I'm just thinking that so if we have like a more subgroup, so we should have enough sample. I mean, that's if we have for each group, and we have the number that enough, so we can do like a sub analysis. It may be possible.
Yeah. So you may use your theory to say, or the literature to say that stress in general is associated with smoking, but there's a stronger correlation among women. And so I'm going to power my study, have a sample size that allows me to look at the general relationship and to evaluate based on gender and gender identity. Yeah. So again, it's based on the literature why you would want to do that additional analysis. Yep, good points. All right, so when we recruit, we want to think about recruitment very early because every study will live and die on how well you're able to recruit. You can have $1 million grant, and if you don't know how to recruit, you are in big trouble. And you can have zero budget, but you very good with know how to recruit, and you can be quite successful. So recruitment is central. My general attitude is that it's a multi-pronged approach that helps you to recruit. So there are passive approaches, such as flyers, posters. There's venue-based, where you go to a community center or activity centers where you would expect to find in the community your target population. So if you're interested in exercise among older populations, you might go to a senior activity place. Clinical setting, you can use the chart review, provider referrals, or recruitment in the waiting room. Social media has become quite effective for recruitment. Snowball sampling. Many people say, no, snowball sampling is not good. Again, it depends. If you are looking at a rare issue or a rare health problem or a rare population or a health risk behavior that is very taboo, like drug use, then snowball sampling is the best approach because people will know other people who are using drugs and that we can use that as a way to help us recruit other people like that. Okay, so it's can be quite effective. And then patient registries. Patient registries are when you work with a clinical population and each of your patients that come through to your clinical practice setting, you say, I conduct a lot of research related to diabetes management. You're a patient with diabetes. How do you feel about signing up for a registry to receive information about future studies related to diabetes? And some people will say yes, and other people will say no. But if you see 1,000 patients over the course of a year and you invite all of them, about 30% will agree. And so at the end of that year, you've got about over 300 patients that you can use at the starting point for your recruitment for your studies. And when you talk about your grant application, you can use your patient registry to show the feasibility of your ability to recruit the patient. So in your preliminary studies, you would say, we have a patient registry with 500 patients who all have diabetes, who have agreed to be contacted about research studies. If I'm a reviewer, I say, oh, they have a starting point of 500 patients. They only need a sample of 200. That increases the likelihood that they will be successful in recruitment. So I would evaluate that in terms of the quality of the proposal and the feasibility. Okay. So patient registries are a great, especially for clinicians, clinical researchers.
Do you have recommendation if we do the random sampling? Do you have like a recommendation for like what strategy that we should use?
Yeah. So using a patient registry and do
No, in general, like if we use a random sampling, do you have like a recommendation?
So sometimes we can do a random sampling by using the electronic health record. And if I'm working with diabetes patients, I have my database has 25,000 patients in it over the course of 15, 20 years from the electronic health records. I select the patients who have been seen in the last 12 months, pull out a separate database, and then I do use a random numbers generator to randomly select patients from that pool. Okay, so there are different strategies that you can use. Even if you have a data set, you can randomly select from that existing data set.
I have another question. Like, I heard that someone mentioned that if you like identify your sample size, like for example, 400, and once you collect data, you got 600, for example, they say it may be ethical issue that increase because its likelihood to significant is going to be much better. You know what I mean? If we got a high sample size beyond the thing that we estimate, like a lot, for example, like 100 or 200. How do you think about this?
So if there's the concern about what? Type 2 error? Is it type? Yeah.
You identify your sample size like this, but you get much more than the result, the result is like a very
Okay. So there are a couple of things that you can do. The first is that a larger sample size can allow you to look at subgroup differences. So I might say that I'm going to oversample, for example, African Americans because they have the highest risk for this, and I want to make sure that I can evaluate based on race, ethnicity. That's one reason to oversample. The other one is that you can say that you will have a tighter significance level because of that. So instead of 0.05 for significance, I might do 0.01. to evaluate the significance.
Dr. Matthew, I'm thinking about Dr. Pariyo's question. So I think he might mean that so if he got the approval for the EC, the IRB, that he will collect the maybe 330, and when he start collect and he see something, for example, there are some group that he would like to expand. So I think in this case he should ask for amendment for the IRB and yeah.
Yes, I see.
How about Dr. Waluni? What do you think about this?
I see, I agree with, I understand better now. So if I have gotten IRB approval for 400 and I see, ooh, my collection of men is quite low. I already have my sample of 400. I write again to the IRB and said, my recruitment was limited in terms of male representation. I would like to propose an additional 200 participants focusing only on males, so that then I could start to look at gender differences in my overall sample. And so you must get permission. It's not okay to keep recruiting. You must get permission to go over the amount. Yes. Okay. Mhm. Okay. Monitoring, proposing how you will recruit using from each of these different approaches, and then monitoring what is effective for your recruitment. So they ask each of the participants when they contact you, they send you an email or they call you, how did you hear about the study? That can tell you which of your recruitment approaches are the most effective. And so you can learn as you're going. And so if I'm using all 5 approaches, all 6 approaches, and only 2 of them are primarily giving me my patients, I know I can now just focus on clinic waiting room and support groups, for example. So keeping track of where people are hearing about the project can help you refine your recruitment materials and your recruitment activities. Question about that? Okay. All right. Okay. Retention plan. Sometimes the study is one-time cross-sectional and you really don't have to think too much about retention. But many studies, we want to maintain our sample over time. So we want to do 1-month follow-up or 3-month follow-up or after the birth follow-up. And we have to retain our sample so that we're powered. Good studies have at least 75–80% retention rate. And so how do we do that? We identify at baseline, are there multiple ways that we can contact patients? Give me your telephone number, your cell phone number, your email address, your mailing address. Tell me your mom's number, right? Think of all many different ways that you can contact them. Sending them regular reminders and text messages or emails about the study visits. Don't forget, your appointment is coming up in 2 weeks. Here's the information. We will see you there. Give us a 12-month follow-up period, like many health promotion interventions. The gold standard is 12-month follow-up. You have to work very, very hard to do retention. And then we send birthday cards, holiday cards. We send them little things in the mail quite often. If you ignore your sample for 12 months, when you come back to them 12 months later, they will not be there. They forget about you, they forget about the study, and then your outcomes are much weaker because you don't have the long-term follow-up. So really thinking in advance how you will maintain and retain your participants. The next thing that we consider is our research setting. Is it community? Is it at the clinic? University, where people come into your lab? Or is it an online setting? Again, each of these have pros and cons, benefits and downsides. But it's up for you to make a good rationale for selecting Oh, I'm going to use a community approach. Why? Older people have more difficulty with transportation, will not likely come to the clinic or to the university. I can use their, the gymnasiums that they go to, or their church, or some other community. So we choose the setting based on how well we think that that will allow patients to participate. Okay. All right. Measurement. Here's the next section that you have to think about. Notice that each of these steps have their own distinct issues that are associated with them. Thinking about recruitment is very different than thinking about theory, but you have to think about recruitment and theory. And so knowing what are the evidence-based approaches for each of these areas in your proposal development is important. Measurement is key. One of the things that I often see is that people say, oh, I don't find a standardized measure, I'll make my own, without doing validation, right? Or systematic instrument development. One fatal flaw for not getting it published. If you make up your items other than a few basic descriptive items, where do you go to church? That's not a big deal. Or how tall are you? That's not a big deal. But if your primary outcome is based such a depression, you want to use a standardized measure of depression, and you want to use all the items. That's the other thing that I see. Non-standardized. The second is that, oh, this measurement as depression is too long. I'm going to delete half the items. Now we no longer have a validated instrument, okay? Fatal flaw, not likely to be published. That it was developed and normed in another country, and that you haven't done the appropriate translation and checking to see whether or not the population here, the reliability and validity is the same as other countries. That's another important thing that has to happen. If you're going to use a scale from another country, it's good to do systematic effort to translate, back translate, work with the expert panel to make sure that all the key issues are there and make sense, and then collect some data to look at issues of reliability and missing data. Okay, this is a good type of project for a master's student to look at instrument translation and validation in a new context, especially if they plan to use that measure for their dissertation work. All right, so that's appropriate master's level work, or it's appropriate for a part of the dissertation. So the first phase is to do translation, validation, and then the second one would be to use those survey measures in a cross-sectional survey. Okay, so that would be appropriate. Okay, so key issues: well validated, never create your own, and never delete some items. The other thing that we want to keep in mind is what are the gold standards for how that outcome or how that construct has been measured. You review very carefully the literature. How do the other experts who are publishing in high quality journals, Q1 journals, how are they measuring your construct? How are they measuring your dependent variable? Is it self-report enough, or do you have to have an objective measure of that outcome? Sometimes it depends. If I'm doing a descriptive study of smoking, and I'm doing a online cross-sectional descriptive survey of smoking, self-report is fine. Do you smoke? Yes, no. Some people may not be truthful, but the vast majority of people will be truthful. But if I'm doing an intervention in which I'm trying to change smoking behavior, self-report is inadequate. You have to have a validated outcome. So if it's physical activity, must have objective measure of physical activity. If it's weight loss, objective measure of weight loss. If it's smoking, if it's medication adherence, those types of things in which there is an actual behavior change that you're trying to increase, then you must have objective measure evidence. Why? Because in cross-sectional anonymous survey, most people will tell the truth. I smoke, didn't smoke, I exercise, I didn't exercise. But in an intervention, they will want to please you. And they don't want to look like they did not do a good job. They don't want to make you feel like you did not do a good job. And so the evidence suggests that most people will not be truthful when it's a behavior change intervention. So that's the reason why you must have a validated measure. In the smoking, my area, I will collect self-report and then I will do an objective measure. There is usually about a 15% difference. So if 15% of those people who said that they were not smoking were actually smoking. So it's really, really important to have the objective measure. And again, that can sometimes be the difference between Q1 and Q3. For intervention research to have an, even if it's a very effective, if the outcome is based on self-report, reject from Q1 very, very, very often. Okay.
I have a questions about how we can identify the gold standards of the measure. Is have to be like the well-known measurement, or it can be some scale that valid enough,
Yes.
or
Yes. So usually, so you might have 5 options. So there might be 5 quality of life measures in your country. First thing that I would do is I would say, who the experts, what are they using? And usually they're using the one that has the most evidence, the strongest reliability, the strongest developmental processes, and the strongest validity. So I would want to use those measures for 2 standardized, well-established measures for 2 reasons. One, you're measuring the reliability and validity that of that measure will be good. And secondly, it allows you to compare your research findings to other people in the literature. That's also critical. So you can say, in our intervention, using similar approaches, similar outcomes, we saw these findings. It's the same as other studies, or it's different from other studies. So you really want to be able to compare your findings to what is also being found in the field. So that's the reason why you want to use well-validated and the most common measures so you can compare. Okay. And again, we go back to our measures table. All right. Measurement time points. For cross-sectional, no problem, 1 time. If you're doing a feasibility test or a pilot test, the standards are at least 1 month follow-up, 1 to 3 month follow-up for feasibility pilot testing. That is showing that, demonstrating that you can retain your study sample for 3 months. You can get them to complete the intervention and you can retain them. However, the gold standard from a randomized clinical trial is 12 months. Why? Because behavioral change is possible short-term, right? I exercise, I set a New Year's resolution, I exercise. You ask me 1 week later, yes, I exercise every day. You ask me 3 months later, not every day. So that is why it has become the gold standard to have not only immediate outcomes, but to have long-term outcomes. It's those both immediate and long-term outcomes that we use to develop to select evidence-based approaches to change clinical practice. Okay, so if we get something that is very effective in the short term, and then 12 months later, no difference between the experimental and control group, then we don't want to adopt that intervention. But if it has strong findings at end of treatment and those differences are maintained at 6 and 12 months, that's the better intervention to adopt. Not just short-term outcomes, but long-term outcomes. All right, sample size calculation. Qualitative, there are rules of thumb between 15 and 20, but the main criteria is saturation. So for your IRB, it is important to propose 25 to 30 participants, but just so that in case you're not reaching saturation, but if you are done, if you have reached saturation at 15, then that's okay. But the reason that you get permission to recruit more is that we don't really know how long it may take you to reach saturation. Okay. For quantitative, it's important to have a sample size calculation and work with a statistician to very carefully develop your sample size. Okay. Yes,
Professor Matthew, I wonder about the rule of thumb for 15 to 20 participants in the qualitative. So you use from the this number come from like which reference or what? Because now they just need the reference to back up,
Yeah, so there are many citations and qualitative manuscripts and textbooks that suggest that on average saturation will take place at about this number. Yeah, so you use that citation, and then if there are other studies that are looking at similar questions, then you can also say Humerman and Miles suggest up to 20 participants is typically appropriate. And these 4 studies reported reaching saturation at 20 participants as well, right? Yeah, so it's good to add the citation. All right. Missing data. Why do we need to plan for missing data? Because if you have a lot of missing data, it makes it reduces your internal validity. You will sometimes not reach your sample size. And it can definitely decrease your statistical power and the validity of your results. So what do I do to ensure that we're not going to have problems with missing data? I recruit a small sample of my target population, and I ask them, first, please look at the survey. How do you think? Too long? So I have them take the test, take all my surveys. I count how long it takes them. So I have an approximate time of how long it takes. Then I ask the participants, was this too long for you? Oh, no, it was okay. Or yes, I was very tired. Then you may need to reduce the number of items that you're collecting, or break it up into 2 data collection time points, or increase the incentive. All right. The other thing is that you say, oh, how about let's look at the instructions very carefully. Was there any instructions you didn't understand? I had to ask this one. I didn't know. So instructions, length, specific words, and to make sure that people aren't leaving items blank. If they're leaving items blank, it means they don't understand or it feels somehow inappropriate to them. Okay. And if you see this in your pre-testing, you want to make sure you understand. If it's because they don't understand, then you can put more information. You can define the word or put more information in the parentheses. If it's inappropriate, then you can select another measure. Okay. All right. Let's see, the analysis plan. Again, consult with a statistician, have a statistician on your team. This is critical. Most of us do not have enough expertise to do by ourselves to do the type of rigorous analysis. So consulting with a statistician can help you with making sure the research design is okay, your sample size is okay, what the analysis plan will be, and to look at your plan for data entry and analysis. So they can be instrumental in each of those ways. When you're putting together the analysis plan, you want to make sure that your analysis plan allows you to answer your research question. Okay, so if you put together an analysis plan that doesn't allow you to appropriately test your research question, then that's not good. So for example, if you have a RCT and you want to look at correlational analyses, it's not correct. Okay. All right, study procedures. This is the approach. Remember, this is the area in which most people will be rejected. People think, oh, I want to help me to improve my English writing so I can get in the Q1. English writing will not get you in Q1. Approach will get you in Q1. English writing is for the editor. Approach is for the investigator and the student to understand. Okay. It is important to learn to be comfortable in English, writing in English, but the most important thing is to be very strong with your methods. That's the best thing that you can do to ensure that you will have a good chance at publishing. And the other thing is, even though you might have used the best methods, sometimes the research findings aren't that good, but even if you use rigorous methods, you can say lessons learned. So we didn't get the outcome. We'd use very rigorous methods. We didn't get the outcome that we were anticipating, but here is what we learned in the process that will help inform the next steps to do this study in a better way. Almost always you can get that published. Almost always. So don't be so concerned, oh man, I'm never going to get it published. I didn't get good results. It's how you frame the results and how you use those, what you learn to help improve the literature for other researchers. Okay. Again, using pictures to describe your procedures is good. This will be the last thing I will talk about, so we can have a couple of minutes for questions and answers. In addition to your project mapping tool, which tells you 25 sections that you need to very carefully consider in developing your proposal, I also recommend that you use an appraisal tool that is consistent with the research design that you're using. So if I'm using a quasi-experimental design, I want to go to JBI or one of the other appraisal tools that tells me what are the sources of error in quasi-experimental designs. And I make sure that I address those sources of error in my proposal, or if those errors or those potential sources of bias cannot be eliminated, then I name them and I will talk about how I will address them in my statistical analysis. Okay, so use one of these types of tools to help increase the rigor of your design that you're using. All right. Last thing I will say here is about your team. Team science. There are very few researchers who can do a whole research project from start to finish all alone. If they do, make them 25 years. I don't know. But most nursing research now is team science. So what team do you need? You need a content expert, someone who knows smoking cessation. You need a methodological expert, someone who knows randomized clinical trial designs or quasi-experimental or phenomenological approaches. You need a statistical expert. If you're focusing on a patient population, you need a nurse or a physician who cares for that patient population so they can help you to understand what types of things may need to be measured, how to recruit, and how to interpret the results. And it could also add another perspective when you're thinking about publishing. You can do the research publication, but then you can work with the clinician to have a more clinically focused publication, right? So team-based science approach can also expand your audience for who you can write your papers to inform, not just so if I do an RCT, I have potentially 3 types of publications. One that is focused on research methodology and design, nursing research, boom. If I am looking at culturally targeted elements and differences based race, ethnicity, then I can look at a disparities focused journal. If I am also looking at recruiting from lung cancer patients and helping them to quit after a diagnosis, then I can focus my publication for a more clinical journal, right? And so those are the different ways in which you're not presenting the exact same information, but you're shifting what you're talking about and what you're emphasizing for different target populations. Research really focused on methodology. Disparities really talking about the differences by race, ethnicity, and what are the predictors that are associated with those differences. And more clinical, how do I take this information and help newly diagnosed lung cancer patients to quit in the clinical setting?
So do you mean for one study, so you can have like a 3 manuscripts for publication, right?
Yes, yes. By focusing on different target audiences. Now, when I'm focusing on, say, for example, a disparities journal, I will do my first publication in a research journal where I describe my methods, my results. When I look at the disparities journal, I will cite, this is a secondary data analysis from this intervention research. Here's what we found, here's the citation. The objective here is to conduct secondary data analysis to look at racial ethnic differences in outcomes and the variables that are associated with different outcomes. So you're not trying to hide the fact that you previously published on the intervention. Now you're doing secondary analysis to answer a very separate research question. Okay.
To make it clear on this, that you can see that Professor Matthews talk about doing the secondary analysis on your intervention study, right? Because now you can see that most of the journal, they worry about the salami, right? About the self-plagiarism. So that's why if you use the same population to publish, in the same population, in same, that's gonna be the problems, because they say that you only publish in this paper, right? But if you do something else like doing secondary analysis, that Professor Matthews talked about, that you do more work on your own, on your previous work. Got my point, right? I think this is a point.
So it's like each manuscript should answer different research questions and
That's
different
right.
data analysis. Yeah,
is
and,
right.
and for the second or the third have to cite the first publication.
Yes, and have to do the first one. So, for example, if I'm looking at a 12-month longitudinal, a 12-month intervention study, it's okay for me to publish short-term outcomes, 1 month to 6 months, and then a second paper that looks at the long-term outcomes. I cite my previous work and say, now we have new data collection. We've now collected an additional 6 months of follow-up data. So now it's a new question. How impactful was this in terms of maintaining behavior change over time? The first question was, can I get a change in behavior? Yes. My second question, second publication is, can I maintain that change in behavior over time? That's perfectly fine, but you're answering a different research question. It is a problem, I agree. If you have 4 variables and you once, and your main study was related to all 4 variables, but paper 1, you looked at 1 variable, and then paper 2, you look at another one, and 3. Unless there's a good reason to do it that way, right? But by and large, it's okay to have multiple publications from that one data set. To be honest, the National Institutes of Health now, if you get a grant, you must, you answer your primary research question, and then you must upload and make publicly available that data set with a description of other variables. You say what has already been analyzed, and then new researchers can come and say, oh, they didn't look at gender specifically in terms of this intervention. I'm interested in this. And now NIH is saying that is appropriate because it's good use of resources. It takes $5 million to do a randomized clinical trial, and to get 1 paper, 2 paper, no. They say the best use of resources is to make that data set publicly available, get new IRB approval for the secondary data analysis, and then allow multiple papers to be conducted using that same data set. Okay? Okay, good. Other questions? I love this discussion. Thank you. Other question? Anyone from online have a question?
Professor Matthew is about the scientific premise that you talk about, that using like the theory, using like theory to make like the path for you to make it like why this study is needed, right? So but then my specialty is about qualitative work. So
Yeah.
then mostly I will use like philosophical, lens to frame on this instead of using the theory. Sometimes you can use like the critical realism as the way that you are to frame your thinking and how you are going to look at the phenomenon, right?
Yeah.
And then you can make it like why it's really needed to study this.
Yeah.
So sometimes you can use like philosophy instead of using a theory on that also for my work. Okay, that's the point.
Yeah. And sometimes that will come up in the discussion. So if I'm doing a qualitative study, oftentimes I will look at what are some, if I'm interested in behavior change and I'm working with a new population, I will look at some of the barriers and facilitators of smoking in a new population. But I'm clear with what my problem is, and that understanding the barriers and facilitators are a way for me to culturally target the intervention to address what is unique about this population, right? And so then as I'm describing the results, I can sort of share how I think these results can be used for future intervention development or for future survey development to see, do these generalize? And if so, how can we make sure that we're incorporating those into our intervention approaches? So I think it's, you maybe do it on the opposite end. Maybe you do it during the discussion and maybe I set it up in the beginning. Yeah.
I think it's another point is about in Thailand, for the master degree, they still need to do the thesis, right?
Yeah. Yes.
In the US, no need to do anything on that, right? For doing like the thesis in order to graduate. But in Thailand, you have to conduct the thesis, and then it's about 12 credits for that.
Okay.
And then for the dissertation, it's about 36 credits for that. So I've been recommend them that, the master thesis and for the doctoral dissertation, how you are going to make the difference between the 12 credits for the master thesis and the 36 this doctoral dissertation, you know, because I found out that in Thailand, most of the instructors seem to be like, they really want to make like the student to be really conduct a good study, right? Sometimes it's over, you know, over 12 credits for the student to graduate. So some students just take like 5 years
Yeah,
for their master.
yeah.
And even for the doctoral dissertation also, how you are going to justify 36 credits for the student, you know,
Mhm.
not to make them to do too much work, right? Because
Mhm.
they are going to graduate and then you are going to work on this 36 credits. So now I think the issue is around how you are going to really identify how much work on each of that, you know,
Mm.
for the 6 credits for the master thesis and 36 credits for the doctoral dissertation. In the US, no need for the master student to conduct any kind of master thesis now, right?
It depends on the
It depends
program.
on the program. Now you still have that, right?
Yeah, depends on the program. Some will do, it's a literature review, a high quality literature review, systematic review. Some will have to do a project, and then others coursework and final presentation or test or something. So it depends. You know, the tension is this: how do we prepare the doctoral student? How do we prepare the master student to come to the doctoral program with enough research training so that they can conduct a high quality dissertation? And how do we train the doctoral student in a way that they have rigorous skills so that when they go to the junior faculty, they will know how to do studies, they know how to train students, and they don't know how to get grants to support. So that's the tension, you know, that's the tension. So, and then some doctoral programs, like in psychology, we had to do both. We had to do continued clinical training all the way through and research training all the way through. It's very common to take 5 years. Very common. Because why? We expect to publish, have a lot of research credits, have to be a research assistant and learn how to teach and be a clinician. So it takes a lot.
And for the doctoral level, right?
Doctoral
But I talk
level
about
in
I talk
psychology.
about master
Or
level.
master level. Mhm.
That some of them took like 5 years.
Yeah, no, it's a problem if they take 5 years for masters. Yeah, it's a problem. It's a problem. So. Any online questions?
So far, no.
Okay, well, I will make the rest of the PowerPoint available. It's some very straightforward information about how do you describe your study team, put together your study timeline, how to get feedback and reviewer information, and then some funding information. So that is pretty self-explanatory. And then also make the paper available. So this presentation was primarily focused on quantitative. My colleagues and I have now developed a project mapping tool for qualitative research that is in press. So it's almost published now. And so maybe if we have time at some point, I can refocus on and share specific qualitatively, or maybe next time I come after the paper is published, we can do a qualitative project mapping. Okay. Yep.
I'm not sure that we still have questions or not. If you are
Any question at the end? No?
If you are online, you can leave your questions in your chat box, either in Thai, we can help you to translate that.
That's right. That's right.
But if not, and you may have question later, you can send it directly to me or to Dr. Matthews. And I think the thing that we learned today is fundamental of research, but it's not just in general, it's in depth, it make me clear clearly understand what we are talking now. You give us a highlight on each dimension of the research mapping tool, which can guide us and our student
Mhm.
to do the better research in the future. So thank you so much. We still have another session. The next one on Wednesday.
Wednesday.
Is about like not
Not
today.
today.
Today is enough.
I know.
Yeah. And the next session is on Wednesday. Dr. Matthew is gonna talk about the research trend. And yeah, and on Thursday it's gonna be like a academic writing.
Academic.
Yeah, we're gonna start the first session on this Thursday. So if you are interested to publish the paper, you can join us and learn about the tips how we can make a record public manuscript. So for today, thank you so much,
You're
Professor Dr.
welcome.
Matthews.
You're welcome. Thank you so much. And for those of you who are online, the template for the 25 items is the associated with the manuscript. It's on as an appendix. So you can take that page, photocopy or replicate it. And as you're developing and working with your advisor, you can use that as a tool to make sure you're covering all the key areas. So good luck with your work, and I hope to see you more during my time here. Thank you.